this. This parish has been very good to the center. We've hosted 2 or 3 clergy conferences here. The center hosts 2 annually, and we're hosting another clergy conference here, in case you forgot, Susan. First Thursday of November, good. And you have been quite gracious to the center. This is also a community event. We did a lot of promotion with area clergy and different media, and so you are certainly welcome to invite family and neighbors and friends. There really is some connection between all 6 of these topics, and the 7th topic, the last week, we're going to talk about really some basic issues around pastoral care and how we care for each other. But tonight we talk about depression, and one of the reasons why we start here is because this is such a huge issue. It is such a perplexing issue, and I think in many ways it is misunderstood. But I want to say a couple of things first. First thing I want to do, and since this is a rather mature crowd like me, somebody should know the answer. And I have a prize here, a brand new Center for Clergy Care and Education coffee mug. And if 3 hands go up simultaneously, I brought extra mugs. And for any Southern Baptists here, it just holds coffee. Everyone else, you're kind of on your own. Okay, we're in a campaign now. I guess you've noticed that we are in the midst of a presidential election. 1972, George McGovern was the Democratic nominee for president. For one brand new Center for Clergy Care and Education coffee cup, who was George McGovern's running mate? Okay. Okay, I'm going to give you the mug, but you've got to tell us the story.
He had in his medical history, I guess, a history of depression, and that was a really big negative. That I think he'd been hospitalized. I can't remember that.
Right. Your question is half correct.
Okay.
In July of the campaign, it came out in the media that Eagleton, senator from the state of Missouri, had been, past tense, treated for depression. He was forced off the ticket and replaced by, there's another mug here on the line,
No.
Sergeant Shriver, Maria Shriver's dad, who was the governor of Maryland. Now, it really didn't matter. This was the year that Nixon won in a huge landslide. I believe Nixon got like 72% of the popular vote. I think McGovern carried one state, his home state. And so it really was not a factor in the election. But in 1972, a Tim Kaine or a Mike Pence was forced off the ballot because he had been treated for depression. Now, fast forward 18 years to 1990. In the state of Florida, and somewhat similar to national elections because we're such a cosmopolitan state to begin with, in 1990, a man ran for governor, came out in the media. He was, present tense, being treated for depression, had been stabilized on 40 milligrams of Prozac, every day for many years. He was elected, served for 4 years, was re-elected, served for 4 years, and will go down, in my opinion, as one of the greatest governors in the state of Florida. And the entire time, he was maintained on 40 milligrams of Prozac every day. Name the governor. Walton Childs. Now, I think it says something about what happened over 18 years. Now, let me tell you another story. Some time ago, I was sitting with a lady in the office who was absolutely immobilized with a significant anxiety disorder and depression. So much so that she was forced to take short-term disability. In a large corporation in Pensacola, a large company with tentacles all throughout the world. Supervisor, worked there for 15 years. Had not received a card, a phone call, anything from any supervisor, any management, any coworker. In talking with someone, she learned that another coworker had gone out on short-term disability about 2 weeks after she did for liposuction, tummy tuck, and breast augmentation, and received from the company flowers and get well cards. One of the things I want to do is I want to normalize mental illness. One of the things I want to do is I want it to be okay to talk about depression and anxiety. I really want us to be able to talk about suicide and grief and bereavement. Many people have all sorts of questions about attention deficit disorder and attention deficit hyperactive disorder. These are important topics. And the longer we stay silent, the more people leave work with depression and anxiety and hear nothing from their coworkers, and I think that's tragic. So tonight we're going to talk about depression. I'm going to talk for about 30, 45 minutes, and then we're going to have all kind of time for questions. But at the same time, I'm much more comfortable with dialogue than monologue. So if you don't understand me, or if you disagree, or if you have a question, please raise your hand. Susan can appreciate this. When I was in theological seminary first semester, and I knew everything then, as we always do in first semester of seminary, I raised my hand with the New Testament professor, and I questioned something he was saying, and he looked at me and he said, "Mr. Winslett, you go your way, and I'll go his." I will not do that to you. I promise. These are the numbers when we talk about depressive disorders. Almost 7% of the entire population in this country over 18 is presently dealing with a depressive disorder. But let me also say that one of the things we know is when we talk about depression, 2/3 of all depressive disorders have an anxiety piece to it. Okay, and so we're talking about Dr. Hodges, my colleague, will be here in 2 weeks to talk about anxiety and some PTSD issues. 1/5 to 1/4 of every adult in this country, not necessarily diagnosed, will suffer at least once in their lifetime with the depressive disorder. 2 times more women than men. But that's kind of a tricky number because, let's be honest, women are much more open and honest and are much more willing to make themselves vulnerable and talk about these things that are important. Men and adolescents often go undiagnosed, and one of the things we may talk about at some point is that adolescent depression most often looks like irritability and anger and volatility. When teenagers are depressed, they don't look sad and forlorn and melancholic. They get angry. Women are vulnerable to hormonal changes, menstruation, pregnancy, miscarriage. A lady finishing some treatment in the office did this little needle point for me, and it hangs in my office. And it reads simply, menopause, mental illness, menstrual cramps. Why do all my problems begin with men? You heard it here. Men are less likely to seek help. And like adolescents, men tend to demonstrate their depressive disorder through irritability and anger. Also, men tend to use alcohol to treat depression. Women, it's not that they don't, men tend to do this more than women. It's not funny, but it's funny when a man will come in the office and receive a clear definition, a diagnosis of depressive disorder, and is at the same time drinking 3 mason jars of vodka every night, and says, no, I refuse to take any medicine. And I say, would you say that one more time? I don't like drugs. Well, alcohol is a drug. Well, no, that doesn't count. Well, yes, it does count. And so one of the things that happens, and we'll talk about this more with substance use disorders, is that we're not about to do anything with someone who is clinically depressed or shows signs of being clinically depressed if they're using excessive amounts of alcohol. One of the things we also know is that if you're going to be given a diagnosis of depressive disorder, if you're going to be given a prescription for an antidepressant, you can't drink. Why can't I drink? Well, what did we all learn in 10th grade high school biology about alcohol? What is alcohol?
Depressant.
Alcohol is a depressant. So it doesn't make a lot of sense to pour a depressant onto an antidepressant. Just do one. Don't waste your money on both. Okay? What are the triggers for a major depressive disorder? Nothing. And people find that very perplexing, that someone can slide into a depressive disorder for no reason. And they get really, really frustrated, and they get really angry, and they ask all sorts of questions about why this can be. But they're the same questions that the 34-year-old asked the oncologist about, why do I have this brain tumor? Where did it come from? I don't know. It's the same question about someone who has been healthy as a horse, eaten healthy, lived a healthy lifestyle, and is given type 1 diabetes diagnosis. What I want to do is say that a depressive disorder is no different than anything else that we have to deal with, but because of the stigmas, some perpetuated by the church, some by others, okay, this has always been off to the side, and so political candidates were forced off of a ticket. Also listen to our language. We do not have condescending, disparaging language about cancer patients or about cardiovascular patients. But we say to people, you're crazy. you need to double up on your medicine. What are some other language? What are some other phrases we have? Anything come to mind?
It's all in your head.
It's all in your head. It's all in your head. Yeah.
Pull up your bootstraps.
Pull yourself up by the bootstraps. We would never say that to a cancer patient. But you might do it once. Okay? Triggers for major depression. Nothing. When I started my practice in '82, we really did not believe that a trauma could be a precipitating event that would send someone into a depressive disorder. We know that's not true now. And we know that a significant loss, a significant death, any significant traumatic event, if not treated, can send someone into a depressive disorder. Grief. We're going to talk about grief in the 6th week. We're going to talk about it a little bit tonight. One of the things we know about grief is that if grief is not treated, if we do not deal with our losses, that can be a factor that sends us into a clinical depression, a major life change, a move, significant conflict. And this is one of the things that is so perplexing for so many. We can send you over to an endocrinologist tomorrow. She can do all sorts of lab work and workups and ask questions and take history, and she can give you a diagnosis of diabetes. Any physician can give you a diagnosis of whatever. Psychiatrists do not have that luxury. We cannot do blood work and say, hey, I'm sorry to tell you, but it's right here on paper, you're clinically depressed. We don't have that luxury. So there is no blood test, there is no x-ray, there is no lab work. But someone presents in the office and they look depressed and have every symptom, and we'll talk about these in a moment, every symptom associated with depressive disorder, but this person has not seen a primary care physician for 4, 5, 6 years, we're not going to do anything until they go see a doctor. Okay? Take some guesses as to what might be going on if it's not a depressive disorder. Any ideas?
Maybe thyroid.
Thyroid.
Menopause.
Menopause. Back to men.
Yeah. Testosterone.
Testosterone. Excellent. Hypoglycemia. Okay? And so why would we start treating something if it could be something that looks like depression? Now the interesting thing, and I don't want to offend anybody, I'll wait till toward the end of the 7 weeks before we do that. A lot of people go to a physician and what they're dealing with is a real significant grief response. And grief looks like depression. But they don't bother to tell, and the physician doesn't bother to ask, what's going on in your life? So nobody says, oh, my spouse died 3 months ago, and it has been hell trying to put my life back together. Well, and so what does the physician do? I mean, you really do look depressed. Well, guess what happens? Nothing. If you wake up tomorrow morning and you don't have a headache and you take a Tylenol, you do not know you have a Tylenol in your body because there's nothing for the Tylenol to do. right? So if we start passing out antidepressants and there's no depression to treat, the worst thing that can happen is you get a lot of side effects, which are not fun sometimes, but there's not going to be any benefit. So let's be certain that we understand that there's really nothing that we can do to make a diagnosis other than to look at a constellation of symptoms that tell us, John.
Can depression be hereditary?
Yes. Excellent question, and it is. Just like poor vision, just like cardiovascular illness, just like cancer, just like diabetes, just like anything else, yes. And one of the things we do when we take a history, we talk about family history. And so what do we hear sometimes? Well, no depression. Gosh, my dad drank like crazy. Well, maybe that was. Okay, so yes, it is hereditary. There are 8 or 9 symptoms that we know go along with a depression, with a diagnosis of depression. And one of the reasons why I did the handouts is so you can take this home and you have this and you can make notes and you can call me with questions if you have questions. These first 2 are really important because for us to make a diagnosis of a depressive disorder, we've got to have one or the other. Most often we have both, but we have to have one or the other, okay? Fatigue or loss of energy almost every day, and that is self-reported or reported by someone who around me is perhaps a bit more honest and a bit more forthright and is telling the truth, okay? Fatigue or loss of energy almost every day. Second is markedly diminished interest or pleasure in activities once enjoyed. And so if you really, really love to get out in the garden, if you really, really love to play golf, if you really, really love to do whatever was your passion, sailing, whatever, and you just don't have it, you just lost interest, okay? That is something we want to pay attention to. Number 3 is insomnia or hypersomnia almost every day. This is kind of a tricky one, okay, because all of us at some point in our life, we don't sleep well. Okay, we're concerned about our family or our kids or whatever, and things keep us up. And there are all kinds of ways to not sleep well. Let me give you like 3. One of the ways we don't sleep well is we can't get to sleep. It takes 3 hours to get to sleep. But once we get to sleep, we sleep for the rest of the night. Okay? Then there are people who can get to sleep, and about 2 hours later, it's like somebody had a stick of dynamite in your ear and they lit it and you go pop, full alert, and you're up for an hour and you go to sleep. And you're up for half an hour and you go to sleep. And you're up and down the rest of the night. And then the person who can get to sleep, 10 o'clock, sleeps till 3 o'clock, pops up, can't go back to sleep. So there are all kinds of ways to not sleep well. Okay? And then there are people who sleep all day. And we see people who sleep 12, 14, 16 hours a day. Every day. Okay? Number 4 is 5% of weight loss or weight gain in 1 month. And this doesn't count if someone's trying to lose weight or if someone's gotten into some really unclean eating habits and they're just kind of grazing all the time. So if you weigh 200 pounds and if over a month you've lost 10 pounds or you gained 10 pounds, you're not trying to. That's a good indicator. Those first four are pretty easy to look at. Okay, they're kind of clear. You can see those and you can measure those. Okay. Number 5, feelings of worthlessness or guilt. Now, the truth of the matter is, and it's unfortunate, we all carry around a sense of worthlessness and guilt. In case you didn't know that, we all have some guilt we have to deal with and some shame. I have heard the TED Talks. TED Talks.
Yep.
Brene Brown. Anything she writes, read it. I read this. She has a TED Talk. They're all 18 minutes on shame and guilt. And I have heard that one TED Talk has taken more hits than all of the TED Talks combined. Now, I find that hard to believe. Okay, but it's a great story to tell. So we're going to believe it tonight. Okay, because we all carry around a sense of shame and a sense of guilt and a sense of worthlessness. And that's just part of the human condition. Maybe the church has something to say about that. Maybe the gospel has something to say about that. But excessive feelings of worthlessness or guilt. Impatient or indecisive. You're checking out at Publix and the lady says paper or plastic and you say, oh my God, paper or plastic. You can't make a decision. Or perhaps you've always been focused and you're finding that you just cannot make a simple decision. Okay? We're talking about symptoms that are consistent with the diagnosis of a depressive disorder. She's one of my favorite people. I've known Mary forever. The next is a sense of restlessness, or somewhat in molasses, slowed down. Remember a long time ago, I had a fellow in the office who was just as nervous and restless and just all over the place. Great job, great family, no stress, nothing. Pleasant fellow. I couldn't quite figure out what was going on, so I sent him to a psychiatrist buddy of mine. Next week, the psychiatrist called me and was telling me about him, and he said, Don, you didn't ask him how much coffee he's drinking. I said, no, matter of fact, I didn't. And he said, well, you missed this one. I said, tell me. He said, he's drinking 5 pots of coffee a day. Okay, in our manual, the Diagnostic and Statistical Manual of Mental and Nervous Disorders, 5th edition, it was the 1st edition when I started, okay? There is a diagnosis for caffeine intoxication. Back to what I was saying about things that look like other things. This guy was drinking 5 pots of coffee a day. And he had caffeine intoxication. But I was thinking I'm missing something about a depressive disorder because of this extreme restlessness. And so I said to the psychiatrist, I said, I guess we need to get him off the coffee. And he said, you really don't know what you're doing here, do you? I said, what do you mean? He said, we need to titrate him down. You don't want to be this guy that goes off of 5 pots of coffee. You're shaking your head, you know. Okay. So it took about 2 months, okay? I think it paid for the kids' new clothes that fall. Because we took him down to 4, only John understands that. 4.5 pots to 4 pots to 3.5. And then we started building in decaf And when he got him down to like 2 cups a day, you would have thought I was part of the Trinity. Okay? This guy felt like $1 million. And none of this was going on. Okay? So if you have extreme restlessness and you're not drinking 5 pots of coffee a day, you need to be careful and pay attention. Or just back to the first one, that just fatigue. Okay? You're walking with concrete blocks tied around your ankles. Okay? Hey, we'll talk about this next week. When we do kind of psychological autopsies after suicides, one of the things we know is that 50% of all suicides, the person is clinically depressed, was clinically depressed. Okay? We also know, and it's not the same 50 people, we also know that 50% of all suicides, the people are not in treatment. Okay? Another reason to stop being silent about this, and let's have conversations about this. And we'll talk more next week about how we have these conversations. Now, maybe I should have put this up at the top, but all of these symptoms, for me, okay, for me to make a diagnosis, I have to have 5 of these symptoms. I have to have 1 or 2, number 1 or number 2, okay, but I have to have 5 of these symptoms that have been present for at least 2 weeks. Okay? Well, let's keep going. Unrelated to a medical procedure, because you know what happens with anesthesia and all the pain medicine and everything that happens post-surgical, it really does work on us. Okay? And so we're not going to make a diagnosis of depression with someone who is post-op or 2 or 3 weeks post-op. And here we go again, unrelated to grief and bereavement. We're not going to make a diagnosis of a depressive disorder on someone whose mother died 2 months ago. Questions? Let's stop right here. And are there any questions? Yes.
I'm real confused about the grief process because like, okay, 2 months ago, 2 years ago, 5 years ago, when is that line of when someone should, I hate to say it, but be getting on with life and getting over the grief and moving forward?
That may be the best question in the 7 weeks. Thank you. If someone is in a grief event and they've been in it for 1 year or 2 years or 5 years or whatever, when do we expect that person to get over it and get on with their life?
Or when do we say it's depression?
Or when do we say it's depression? And that's a great question. And the best answer is, I don't know. Okay? My response to my mother's death is going to be different than your response to your mother's death. Okay? My dad died when I was 19. I was first semester sophomore in college. I was 19, he was 50. We could probably go around and round up a bunch of 19-year-old white males from the Deep South who were first semester sophomore in college, whose 50-year-old fathers died. Okay? And we could all get in a big room, but I can never say, fast forward to week 7, I can never say, I know how you feel. I can say, I know how I felt. I know about my pain. But I can never presume to know how you felt, because that's a different relationship from my relationship with my dad. Okay? That is such a great question, because there is not a great answer. Okay? And I think at some point we have to stop being silent. We have to trust ourselves with our rector or with a referral or with a primary care physician and say, I've got all these symptoms. It's been 2 years. I've not gotten over it. I'm still struggling. Do we need to try something and see if it works? That's why we say doctors practice, because we don't know. Okay? That's a great question. Any other questions? Yes, here and then here. Here.
A lot of the issues that you describe, and it's my generation or where I come from, you suffer when you lost your job, when you have a serious defeat. And in a way, culture have thought, well, you need to fight it over, and you need to get over it.
Yep.
So, and that can be a process that is a week or can be a month until you get back on your feet and you move forward. So how you distinguish one from the other? How you distinguish the two depression? Was that a depression event that you were able to snap off it? Or is that a depression event that you will carry on for the rest of your life and you never got over it and you just cover it up?
That's a great question. And it's a similar question. How do you know if we're talking about a response to grief or if we're talking about a depressive disorder that's set in? I think one of the things we look at, again, back to John's question, is we look at family history. Is this a family that was prone to depression? Okay, and so it may be that what we're dealing with is something that was started as a trauma and kind of eased its way into a depressive disorder. This is where I think, and I don't like my answer, okay? This is where I think we have to be able to trust somebody and stay in conversation with somebody. Squirrels. Squirrels. It's the Auburn engineer. Roll Tide. Anyway, I should have said that. So I think that's what we have to do, is we have to be able to trust ourselves with someone and enter into conversation, and we may have to try some sort of chemical intervention and see if it works, but that's way down the line. Sir?
Yeah, and I would be concerned that, and I would be, since that you talking about the coffee and fever and everything like that, you can not do anything with no other thing, but two things you can either, get somebody that know what they're doing.
Yeah.
Either keep getting the Lord in hand, because I have been in like, a season, like, a long time. Like, a long time ago when I was born, so, I know what you're talking about, because, I didn't know I was gonna get out of season and then have hot fast and everything. And I used to take medicine, and this used to be like so bad that you can't heal. You can heal, but you can't see nothing. All you can do is hear somebody tell and like let you relax and just like that. And then but I got so better, but I stopped having seizures. The doctor told me like, and I got heavy seizures. She was gonna take me on medicine. So like, I had got having my seizure, and the doctor took me out medicine. So you can't do nothing about it, but them two things right there.
Okay, thank you.
I lost my wife 18 months ago. It's been very difficult. But I was seeing a licensed mental health counselor in Pensacola, Florida.
Okay.
And on one session he said, well, how long has it been since your wife died? I said, 8 months. He said, well, it's time you got out there in the city and saw some ladies and had a good time. And I
I'm
said,
sorry.
I said, grief does not have a calendar,
Thank you.
but you and I do, and we're through.
I'm sorry that happened to you. I appreciate you telling that story. And this is why y'all are gonna invite neighbors to come in and we're gonna talk about grief and all this other.
Don,
Yes,
are the symptoms different for children?
depression,
Yes.
it's hard to say, 7, 8, 9, 10, 11, 12. Depression looks like what we're talking about here. We ask questions about sleep and appetite and mood. We ask questions about socialization at school. If someone's work performance decreases with kids, we talk about academic school performance decreasing. Okay, we stay in touch with the teachers and school counselors. Again, with adolescents, we see a lot of irritability and anger and volatility. Okay, I think the suicide PowerPoint has a, excuse me kids, I apologize, it says adolescence is like a house on moving day, a temporary mess. And that's the way it is, but it's also a mess for adults, so my apologies. But anyway, yes, kids, preschool, but walk around an elementary school for a day and then walk around middle school for a day and see how you feel within those 2 days. Because they're different. Their bodies are exploding. Everything is different, and the depression looks different for teenagers. It really does. Okay.
People that are depressed and just sleep all the time, is it from the fatigue, or is it like to escape? Or
They feel fatigued. It's not all in their head. They are fatigued. Okay. What we don't have the ability to do is to say, you're moderately depressed. See, here's the blood work, or here's the x-ray, or you're severely depressed, or we got this depression that's really coming on, let's treat it while it's not such a big deal, okay? But in a full-blown depressive disorder, and to someone who sleeps all day, they need to sleep because the chemistry's not right, and it's sending signals that they need to sleep. Okay, it's real. Okay, a lot of people avoid treatment. Well, people avoid treatment because they're afraid. But you know what? People are afraid to go to their oncologist also. How much easier would it be to treat stage 1 tumors than stage 2 or stage 3 or stage 4 tumors? One of the things that we're trying to do, the group that is least likely to get help in this city and in every city, the group least likely to get help, clergy. You know why? Because they think, and you think, that they got vaccinated the day they were ordained. They got this shot, okay? And they're immune from all of your incivility. They're immune from all the petty stuff that happens. They're immune from getting sick themselves. They're immune from having family problems or financial problems or parent problems, okay? And unfortunately, in the language of tumors, Clergy typically get help when they're stage 3 or stage 4, which means when they're a train wreck. Okay, so there is the fear of getting help. There is the social stigma of getting help, about getting help. I can't do that. I can't go talk to anybody about this. This is so embarrassing. And a lot of that's the old messages about mental and nervous disorders, that it ain't real anyway. I just need to pull myself up by the bootstraps and go on with it. Okay? And denial. I think it was Pam Tillis that recorded the song Cleopatra, Queen of Denial. And so we have a lot of people who say, this is going to get better on its own. But let me tell you something else, okay? 70% of all cardiovascular deaths, heart attacks. 70% of all cardiovascular deaths, the physician should write on the certificate of death, guess what?
Okay.
Denial. 70% of all cardiovascular deaths, the person had symptoms at least 4 to 6 to 9 to 14 days before the event. 7 out of all 10. Only 3 people just kind of like fell over and died. Okay? And again, I don't want to hurt feelings. I'm one of those who should have died. I was 48. I had symptoms for a week. I was afraid. I was in denial. I coded in the ER at Baptist Hospital and died twice. Woke up and saw one of the chaplains, thought I was in hell. It was horrible. So we avoid treatment for these reasons. You had a question. Did you have a question after that?
Well, I just want to comment. I'm the one Southern Baptist. I grew up Southern Baptist, but I didn't.
Okay, welcome.
But I'm really thankful for you bringing this out, because it is something that has a huge stigma. Can you hear me?
I can.
In the church. And it's something I've dealt with for about 15 years. All the time. But one of our pastors, a young pastor, he's on medication for it. And he had a guest speaker that was, he made fun of ADHD. And on watching him, I know about that too. One of them asked him if he did. And he said he did. He's 48 and he just got on medication 2 years ago. So it is getting better.
Good. So there's one Southern Baptist on medicine. Amen. See those hands. Thank you. I don't want to take antidepressants. And we come back to shame. I shouldn't feel this way. I shouldn't be this way. I should be able to get over this. I should be able to shake this off. We would never say that about heart disease or cancer or rheumatoid arthritis or ALS. We would never say that. Yeah. This is 2016.
Can
Come
you
on.
also say people avoid treatment because of cost?
No, you can't say that. There is growing evidence, and I believe this completely, that untreated depression does exacerbate other medical problems. We know there is a high incidence of cardiovascular patients who had a preceding depressive disorder untreated. We know there's a connection between depression and cardiovascular disease, just as an example. wrong way. What does treatment look like? Treatment looks like sitting and talking, psychotherapy. There really are a lot of people who are quite sensitive to medicines and who can't tolerate any medicine of any kind. So there are a lot of people who simply cannot take psychotropic medicines. You'll be either very, very happy or very sad to know that the FAA does not allow commercial pilots to take antidepressants. I personally think that they should all take them. And that way we can snag the ones who are depressed and we'd all be safer. When friends and family are flying somewhere, I tell them, I'm not praying for you, I'm praying for the pilot. You're kind of passive in that process. I remember working with a pilot, commercial pilot, several years ago, very, very, very depressed. Could not take medicine. Wanted to take medicine, was tempted to go ahead and take it anyway, could not take medicine. And we kind of got into a little banter every now and then because he would tell me his schedule for flying so I wouldn't be on his plane. And it got to be kind of fun. Okay, but there is a process called cognitive behavioral therapy. Dr. Hodges is going to talk a little bit about that, really a lot about this when he talks about anxiety and ADD, ADHD, where what we want to do is have you to let this part of your body take over and rule this part of your body, where we pay attention to what you're thinking and the oftentimes irrationality of your thinking, and how we can help you to change those thoughts. Now go back to the symptoms, to think about excessive guilt and worthlessness. Okay, and how do we help someone to begin to do something different with how you think about yourself? And so we talk about psychotherapy, cognitive behavioral therapy, and antidepressants. Now, I'm kind of on thin ice here because I'm not an MD, and I'm grateful for that. But let me tell you about antidepressants, okay? There are three chemicals in the brain that we're paying attention to: norepinephrine, serotonin, and dopamine. I do something? Okay. The best illustration anyone's ever given me is really quite clever and quite simple. Imagine you have in your brain, you have neurotransmitters, and neurotransmitters are connected by the synapses, okay? And the theory is, we don't know this, the theory is that the neurotransmitters get dirty. And the image is like the old days when your old truck up at the farm and it wouldn't start and the spark plugs were fouled. Remember that? And somebody would go and pull the cap and would scrape the carbon off the spark plugs, put the caps back on, and fire up the old truck. Okay? The theory is that the neurotransmitters get dirty, just to use good old language, okay? And they can't fire. And in the not firing, we see all these symptoms, because these symptoms are regulated by different parts of the brain. Okay? And so what the medicines do, the medicines go in and cleanse, scrape the carbon off, cleanse the neurotransmitters. Now, one of the things that we know is that, and people say, well, why are there so many antidepressant medicines? That's crazy because there's only depression. Well, Why are there 12 medicines for hypertension? And why are there 50 different cocktails for chemotherapy? And why don't we all have the same vision problems? Because we're different, okay? And so one of the great things about heredity is that if I had a parent that was maintained successfully on 100 milligrams of Zoloft, good possibility that if I need to be on medicine, I'm going to be well maintained on 100 milligrams of Zoloft. So we kind of get a leg up with something like that, okay? So this is what we understand to happen with the medicine. One of the things I should have put on the handout, I think doctors do a good job in telling patients this, but I think sometimes we're so overloaded that we don't hear everything, and probably sometimes doctors don't say everything. These medicines do not work quickly. You may know that. Okay? This is not Advil. Okay? A good SSRI, selective serotonin reuptake inhibitor, is going to take 2 to 3 to 4 weeks. Okay? Now, if you don't know that or believe that, and let's say you start taking it and you feel a little nauseated, that's sometimes a real common side effect. Maybe a little lightheaded, maybe extremities tingle a bit. You know, that's to be expected. If you don't understand that it's going to take 2 to 3 to 4 weeks for the medicine to kick in and work, what do people do? This is crazy. I feel worse. Out of here. Okay? And so what happens is, then they get frustrated, all the stigmas, all the denial, everything kicks in, and we've taken 2 or 3 steps backwards. Okay? These medicines always take 2 to 3 to 4 weeks. Now, if you're talking about benzos, you know what I mean by benzos? Everybody know about benzos? Xanax, which is alcohol in pill form. Librium, Ativan, Valium. Okay? Those are really quick. And sometimes they're used successfully for really significant troubling onsets of anxiety that can tamp the anxiety down. But those work very quickly. But you got to make sure you know what you're taking and what it's going to do to you, okay? Yes?
You said it's like a pill form of alcohol. Does that mean it's kind of like a depressant? You need a depressant?
It's highly addictive. We don't like Xanax if we can avoid Xanax. Okay, because it really is highly addictive and do what?
That whole group is very difficult to get off of.
The whole group is very difficult to get off of. It's a lot of fun to be on it, but it's tough to get off, okay? It's kind of like some of the stimulants that we'll talk about, all the Adderalls and all that stuff. Okay, good case scenario. Let's say that after 2 months you feel like $1 million. Okay? Winner, we got it. Okay, right medicine, right dosage, we're great. Okay, and so you say, man, this stuff's not cheap. I hate medicine. I miss my wine, whatever you say, okay? No. You're going to use this medicine for 9 to 12 months. I don't care how good you feel. Because what we know is that your brain has not fully healed in 3 to 4 or 5 months. It's kind of like we got all our kids in braces, okay? And when the braces come off, if the orthodontist doesn't use a retainer for another ever how long. What happens to the teeth? It's the same thing. So we're gonna have somebody on this medicine for 9 to 12 months. Okay? No question about that. And we really push that hard. And people don't like to take medicine, people don't like the cost, the inconvenience, It doesn't matter. If you ask any physician, there are two things that really bug physicians. First is having to do with insurance companies. Okay? Second is patient noncompliance. Drives physicians just
Would you say that again, patient what?
patient noncompliance. Yeah. Yes, sir.
I can admit to being one of those.
Oh, I don't know how to respond. Thank you.
It's a common thread with people I know that,
Yeah.
And the other thing they need to know is that except for Prozac, which has a long half-life, very often you have to wean down.
Well,
Just like you wean up when you're already done.
thank you. Yeah, you don't titrate up, you don't titrate down. And so what happens is people after 3 months, they feel like $1,000,000. They toss the medicine, and 2 days later, they are sick as a dog. Because most of these medicines, you have to titrate down. You have to go every other day, every third day, half dose for, it's kind of like the guy with the 5 pots of caffeine, okay? You have to, slowly come off of it, okay? Now, let me put in something here. I couldn't find the article, and so I didn't want to put it up here. But let me tell you what we know. What we know is that if someone has an anxiety, depressive disorder, and they go see a licensed mental health counselor or a psychologist, a non-MD, okay? Those people get better at a rate of 33%. Now let me tell you something else that's pretty startling. If someone goes to see a psychiatrist or a primary care physician, I prefer a psychiatrist. We can talk about that if you want to. Go see a psychiatrist, gets a good diagnosis, clear diagnosis, starts the right antidepressant. They get better at a rate of 33%. If someone becomes involved in both modalities of treatment, psychiatrist, psychotherapy, cognitive behavioral therapy, they get better at a rate of 87%. Wow. Now, this raises some issues that I don't want to get into it because it raises all kind of crazy issues about insurance companies and their refusal to pay for 2 mental health professionals, anti-medicine. It raises all kind of issues about time, about money. Okay, but one of the things we know is that when people move into a depressive disorder, they get into what AA guys call stinking thinking. They make bad decisions in family, bad decisions in life, bad decisions in business, all of the excessive guilt, all the things we talked about, okay? And just because the brain kind of heals, they still have these issues here to deal with, okay? And so I'm the most blessed psychologist in town, okay? Because we got a really cool place where we work. And I've got a psychiatrist out the other end, okay? We did it that way so we could be like far apart. But I'll send somebody down to him. And he'll send them back and he'll say, no, they have too much stuff to work with. I'm not about to medicate that. Y'all work for 2 or 3 months. If nothing gets better, send him back. Wow. Okay? Or he'll send me somebody and says, what do you think? And I say, I ain't doing this until you get this guy stabilized. Okay? It goes back and forth. Okay? People get better. People really, really get better. But they get better when they involve both modalities. Okay, and what I always say, and Susan knows this, I say, do you have a pastor? Because there's a component here that you need to pay attention to. And that is your spiritual component. And what are you doing with that? Because that is part of your healing. You've got to be involved in that part. That's got to be part of your life.
You said the 87% recovery, the psychotherapist and which other group?
Psychiatrist.
So does that mean they're taking the medicine
And talking.
and getting the psych?
Yeah, they're
At the same time.
they're doing the right method, talking through these issues. This is kind of my issue, so y'all bear with me. You don't have to listen to any of this.
Is there some placebo effect because people are just getting treatment, whether it be from the...
That's a great question. There have been studies in large mental health facilities that had large waiting lists, and they did 3-month waiting list, and they did research on the people who were on the 3-month waiting list. On the waiting list, never got in. They had an appointment. 33% got better, 33% got worse, 33% stayed the same. So how do you figure that? Yeah, I think there's some placebo effect, but I think we can talk about that in any specialty of medicine. We're never going to say, get your lazy self to the gym and stop taking your antidepressants. Okay, I'm not going to say that. But I am going to say, if you have to choose between seeing me and doing an hour of yoga, go do the yoga. If you have to make that choice, and you have to choose one or the other, I vote for the yoga. Okay? We are so sedentary. Okay? Effective treatment for mild depression, exercise. Remember the 3 chemicals? Endorphins is one. We call them endorphins. They swim all around everywhere. Exercise releases the endorphins. Exercise does what antidepressants do. Okay? I think part of the treatment is good diagnosis, psychiatrist if necessary, talk therapy, psychotherapy, exercise, and food. We do not eat clean, okay? That affects our overall health, okay? And so this becomes a really, really important part of treatment for depressive disorder. I'll never say it to you, okay? I promise, but I do say it to people in the office. You don't deserve to feel good. You are doing nothing. You are doing nothing that would enable you to feel good. Well, I resent that. Well, okay. And so we have to ask ourselves, if we always feel bad, what are we doing to not feel bad? Well, there are a lot of people who aren't doing anything. And they expect to feel good. That's kind of strange. psychiatrist, talk therapy, antidepressants, exercise, food. And again, people really do get better. But one of the things we know, the longer you wait to get treated, the longer it takes to get better. But the same thing is true for a sinus infection. If you wait 2 weeks to go see your doctor for a sinus infection, you're going to get 14 days of an antibiotic. If you wait 2 or 3 days, you're going to get 7 days of an antibiotic. Well, there's a reason for that. The longer you let this be in your system, the longer you are sick, the longer it takes to get treatment, the longer it takes to get well. We have 15 minutes for questions. Susan.
You didn't mention electroshock or any of those kind of things. Is that something, treatments that you see a lot or not?
Yeah, that's a great question. I consciously chose to just not do that. What Susan's referring to is electroconvulsive therapy, and it is a last resort for stubborn depressions that don't respond to any treatment, don't respond to 4, 5, 6 different antidepressants over a significant period of time. We do ECT at Baptist. I think Florida now does ECT. And basically you have electrodes planted in a couple of places, and it is a brief shock electroconvulsive therapy. And what it does, we think, is what the medicine does when it works. There are people who do very, very well with ECT. There are people who lose memory, who lose their ability to find their way home. There are people who take unilateral ECT or bilateral ECT. And there are 2 or 3 psychiatrists in town who do a good job with this. And I'm always happy to be a triage kind of person. Good question. Jennifer?
So if we know someone that has been diagnosed with clinical depression and they're doing the things that you mentioned for treatment, they're doing all the right things, they're seeing a psychiatrist, they're a mental health care person, they change their diet, they're exercising, and they're doing great for X number of weeks or months, and then we notice a backslide. How do we as a friend, as a neighbor, help them or support them
Okay.
get back?
That's a great question, and it's something I didn't include here and should have. Let me answer my question first, and maybe it's yours. Someone goes through treatment, they're on medicine 9 to 12 months, they do well, they come off the medicine, they're doing fine. A year later, they have a reoccurrence of depression. Okay? We can go ahead and guess that we start the treatment back, we do the treatment again. I forget the numbers, but there's like a 50% chance there's going to be a third event. And if there's a third event, there's a 80% chance there's going to be a fourth event. Okay? So at some point, what we have to say to people is, this medicine is going to be part of your food plan for the rest of your life. And this is what you're going to have to do. And so our psychiatrist, I bumped into a lady at the office this morning who sees a psychiatrist once a year. And she gets her refills for the year, and she's doing great. But she went through this 3 or 4 times with reoccurrences, okay? Now, if you're talking about someone who is still in that first 9 to 12 months, and they're 6 months into it, and they've done well, and all of a sudden, well, something's happened in their life that they need to take a look at, pay attention to. Or sometimes brain chemistry changes and somebody needs to be changed from one medicine to another, or the medicine they're on needs to be increased. Okay? And this is why I prefer a psychiatrist, okay? When my knee went out, I did not call an ophthalmologist. Okay, I called an orthopedist, okay? And because that's what they do, okay? And so I prefer a psychiatrist, and a really good psychiatrist in town, because someone who is in the middle of treatment and doing well and tends to slide back down, there could be several reasons for that. Another life event, another trauma, the medicines could be not doing what they're supposed to do. There could be a need for increase in the dosage. Person could have started using alcohol heavily. The person could have gone to another physician and started another medicine for another medical issue, and the medicines don't work together. So they're just all sorts of things. What I would do is encourage the person to get back to the caregivers, and let's crank this thing up and see what's going on. Is that kind of what you're at? Is that good?
Yes.
Okay. Mary?
What place would you give group work in this process?
I love group work. It is a management headache, trying to get in this world, trying to get 6 or 7 people in the same place at the same time, doing the same thing. The genius of group work is seen in AA. And as Fred Biegner once said, if you want to see what church is supposed to be like, go to an AA meeting. Okay, and so it's if we can put that. I don't have any groups going right now because there's such a management issue. Okay, but to have 6 or 7 people who are clinically depressed, that's a powerful experience if they're in there and open and working. Okay, so it's a good question. Let me point you to one resource, and you'll be proud to know who wrote the book. I loaned my copy, and I don't know who I gave it to. There is a book titled Jesus Wept. And I really wish every one of you would go on Amazon and buy it. It is written by Barbara Crafton. Barbara she's been here, some of you may know who she is. Barbara is a kind of retired Episcopal priest. She herself has a stubborn, depressive disorder that has come and gone for years and years and years. And she wrote this book. In fact, Mary introduced me to Barbara's work, the sewing room. Yeah, had Barbara here for a clergy conference when you were suffering for Jesus in Hawaii, I think.
Right, exactly.
Yeah, that's how I remember. Nobody's depressed out there. And it is a great book. What it is what she calls an ask book. She has a number of people who read her daily devotions, and so she asks people to write about their experiences with depression and their loving family members and caregivers to write about depression. And she compiled this book, Jesus Wept, shortest passage in the Bible. Barbara Crafton. It would be a great book for you to use in a study group. It'd be a great book to read. I have probably referred 100 people to that book. It is phenomenal. And so that would be a good book to read. Yes?
Do you think we need to reevaluate some of the mass discharges from the mental hospitals, because we have many people on the street that are not being treated, that are really sick?
Yeah, that's a great question, and that gets into public policy and insurance companies and
Well, a lot of it had to do with coming about, beginning with Nepal and going forward.
yeah. Tell you an interesting piece of history in Americana. 1966. 1966 was the year that, I think it was 66, was the year that lithium was, came on the market. Lithium was for many years the primary treatment for bipolar disorder, but used to call manic depression bipolar disorder. 1966. 1966 was also the first year in this country there were more discharges from state mental hospitals than admissions, which is phenomenal, because they started using this medicine for all the bipolar patients who got better, got stabilized, and got home. But we do have we have a population that is not served because of all the reasons we've talked about, because of funding.
And some don't want to be served.
And some don't want to be served. Absolutely. But there are some people who don't want treatment for their cancer either. So, question.
After hearing your story about the doctor, how do you go about finding someone good? I mean, what's that process?
Not the yellow pages.
Okay.
You talk with your primary care physician, you talk with your pastor, you talk with friends and neighbors. And I also would say that a first visit, I think a first visit with any physician, any mental health, any healthcare provider, first visit is a mutual consultation. I mean, I have the right to say, I just don't think we're a good fit. Okay, you have the right to say this doesn't feel right. Okay, and a lot of people think that there's something wrong with them, or something funky's going on with them, and so they need to keep trudging away. That's not a good fit. I mean, this is a whole different process than an internal medicine guy taking blood and saying, here's blood work. That's different from somebody sitting down and talking about really personal, intimate issues. Okay, I think the church is a place to go. I think primary care physician's a place to go. Good question. Yes, John.
I just wanted to say briefly, some of you may want to know what antidepressants feel like. And I'll tell you firsthand, I've been on antidepressants for many years, and I sure fought taking them too. I didn't want to have anything to do with them. I quit a couple of times, suffered for it, and I've also had the doses tweaked. But I just want you to know my experience with antidepressants is, I believe in them so firmly. It's that they do their work quietly. You don't feel a buzz or high. You just begin to feel better again. And it does take a while. You have to be patient. But makes me feel what I like to call normal. And it's been quite an experience.
We need more people like John French to say what he just said.
Well,
Bless you. Yes.
I'll concur. I was fixing to do the same thing. I've dealt with it for 13, 14 years.
Yeah.
I come from a family that were alcoholics, so it bothered me with hereditary.
Yeah.
But it is a difficult path to take, and I'm a sold out 100% believer. I read my Bible. I love Jesus, and it's still been. I mean, I quit and suffered. I did that not long ago, and I'm going to start back up, and I'm on my journey again.
Yeah.
But for whatever reason, I mean, yeah, even for yourself, it's hard to keep taking it. It does seem to don't like doing it. It's hard to think it's up.
Yeah.
And I read a first book I ever read. Well, actually, depression caused me to become a reader. I read a lot about it, but my pastor thing, I said, don't talk to somebody that doesn't have it, because you don't understand.
Yeah.
A person's never been there, you can't imagine what it's like unless you've been in depression, real depression.
That's true.
So, if anybody wants to give some advice about the depression, like he said earlier, you can't get it.
Yeah. Every diabetic knows what it feels like to be diabetic and knows what it feels like to get regulated on insulin or metformin or whatever. And what the diabetic says is, wow, it feels so good to be normal. It feels so good to feel normal again. And we all understand that. But it's hard for some of us to understand what John said, but it's the same thing. Okay, it's the same thing. Because a part of your body is not working. It's not normal. And now it's normal. And that's the way it's supposed to be. Okay? What we're going to see next week is that depression is a huge component in suicidal behavior. And so many people who attempt and complete suicides are clinically depressed. Okay? So I think the conversations do start here. And I appreciate your attention. I appreciate the wonderful questions. I appreciate the hospitality of Susan and St. Christopher's, and hope to see you next week. Grace and peace. Thank you.